Hey friends, welcome back to the Journal Feed. My name is Nick Zelt, and this is the only place to get spoon-fed the latest and greatest of emergency medicine. This is the audio version of the past week's summaries, which this week were brought to you by our authors, Kitan Patel, Joshua Belfer, Rebecca DeFabio, Millie Casse, Clark Strunk, and Clay Smith. Okay, now the first article titled Initial 12 milligram versus 6 milligram adenosine for supraventricular tachycardia in the emergency department out of the Journal of Academic Emergency Medicine. You may recall that somewhere around a year ago, we covered an article on this, looking at the initial dose of adenosine for SVT treatment. That was a pre-hospital study, but they were comparing also 12 milligrams to 6 milligrams and seeing if, hey, maybe you'd be better off just starting with 12. Although there's not actually that much data on this subject, and so these authors wanted to also look into it. This is a prospective observational study which compared in their emergency department 12 versus 6 milligrams of IV adenosine for the first-line treatment of SVT. They wanted to see what were the success rates and were there any differences in complications. Now, from previous literature, it seems like if you go with 12 milligrams, you get about an 80% success rate. And if you go with 6 milligrams, you get a 55% success rate. And what did they find? Pretty much identical to that, actually. If you start with 12, 83% success rate in ending SVT, and if you go with 6, 52%. That's a number needed to treat of about 4, which really isn't so bad. And they didn't see any difference in adverse events either, although there's not that many for adenosine. It's really quite safe because it's such fast onset and offset. Since no matter what, since this would be part of your standard progression of treatment, if 6 failed, you'd go to 12. Personally, I've started just starting with 12 and then moving on from there. I don't see any real reason to start with 6 when it's just lower success rates and no differences otherwise as far as I can tell. So personally, I've switched over to just go big or go home, start with 12. And it seems to be a legitimate approach with higher success rates. That being said, if you start with 6, while you're more likely to fail, you're not really wasting much time, and there's not really going to be that many more other side effects. So you want to start with 6? Start with 6. I think that's totally fair too. So in a spoonful, 12 milligrams as the starting dose of adenosine for SVT seems like a pretty good way to go. It's the next step anyways, so I say why not just go for it. Okay, then let's skip to the fourth article, titled Immediate versus Delayed Coronary Angiography After Cardiac Arrest Without ST Segment Elevation, 5-Year Outcomes from the COACT Randomized Trial, out of the Journal of the American College of Cardiology. All right, who remembers the COACT trial from 2019? It's a very similar trial to the Tomahawk trial, which came out a year or two later. And just like the title implies, this is coronary angiography after cardiac arrest without ST segment elevation. So they wanted to see whether or not it was beneficial for patients to get either immediate or delayed angiography after you got ROSC from a cardiac arrest, and whether or not you had ST elevation. If you have ST elevation, then the argument was that, well, you should get immediate angiography to see if you need PCI. However, they weren't sure if all patients, even without ST segment elevation, should go for angiography to see if you need PCI. And of course, the idea is not crazy because a lot of out-of-hospital cardiac arrest is due to cardiac causes. So maybe some proportion of these people would, benefit from a stent, even if they don't have a STEMI once they get ROSC. Now, the original trial from 2019 showed no benefit at 90 days, and they'd already done a follow-up as well at 1 year. Now, this is the follow-up at 5 years. I'm going to say that they have impressive follow-up data, 93% of the original 552 patients. I guess that's the Dutch for you way to go, Netherlands. But unfortunately, even at 5 years, we saw no significant difference between the groups. So getting immediate angiography without having an ST segment elevation may not be beneficial. Now, in these days, things have changed a little bit since 2019. We talk a lot more about STEMI equivalence, although there has been some studies that show low diagnostic accuracy for ACS post-ROSC, even for STEMI equivalence. Maybe things would be slightly different these days if we were incorporating more of those occlusion MI paradigm cases. But it's not altogether certain either. The authors in the introduction call this the definitive test for this question, and I find that very strong wording. I'm surprised it got past editors, but it is still probably the best test that we have so far, since these are the longest term outcomes that we've seen. Maybe Tomahawk will be able to do 5-year outcomes at some point, but they haven't been able to do that yet because it hasn't been that long. Altogether, though, I'm not at all surprised that 5-year outcomes would be the same. If 90-day rates of survival were the same and everybody still gets an angiography. So I can't say that I would expect a difference. Well, not everybody gets an angiography. Actually, only 64% of the delayed group actually got angiography. But all the same, I don't think that everybody necessarily needs an angiography. Especially if you're not having a STEMI, prophylactic stenting has not been shown to be helpful, and so we wouldn't expect a difference from that either. So even if more people happened to get angiographies and got stents for lesions that were not the culprit lesion at the time, then we still don't expect that to actually help them. So even from this study, and it's not going to change anything for your ROSC patients, not all of them should immediately go for angiography, still. In a spoonful, 5 years later, there's still no benefit to immediate angiography after ROSC without SD elevations. Okay, that's all the 5 articles from this past week. Let's do a quick wrap up of everything we talked about. From the first article, just go for it. Start your SVT treatment with 12 milligrams of adenosine and see much higher rates of first treatment success. Then from the fourth article, still no benefit to angiography after ROSC without a STEMI, even 5 years after the original COACT trial. All right, if you're hearing this right now, then you are not a part of the members feed. So you missed 3 articles from this past week. What were those articles that you missed about? Well, we saw a SIRMA that identifies the risk of invasive bacterial infections in infants aged 60 to 90 days old. We saw the development of a pediatric sepsis event monitoring algorithm. And then finally, how much calcium should you be giving with whole blood to optimize your mortality? Links to all the original articles can be found at journalfeed.org or just follow the links in your show notes. Our goal here is for you to keep up the easy way of spoon feeding. Thank you.